Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I have the pleasure of being joined by two huge names in the field of sleep and airway, and they are Doctors Steve Carstensen and Jerry Simmons. Dr. Steve Carstensen is a dentist who graduated from Baylor College of Dentistry and has practiced in Texas and Washington. He achieved fellowship in the Academy of General Dentistry and has devoted a significant amount of time to the area of sleep medicine. A lifelong educator, Dr. Carstensen is Sleep Education Director for the Pankey Institute and lectures on the subject at Spear Education. He was a program chairman and general chairman for the American Dental Association annual session and is the consultant to the ADA for sleep-related breathing disorders. Dr. Carstensen is also co-author of a textbook designed to help dentists recognize and manage airway disease in their patients. He's been a board member, secretary, and president-elect of the American Academy of Dental Sleep Medicine and has achieved certification by the American Board of Dental Sleep Medicine. He has dedicated a significant amount of time and energy to educating his colleagues on sleep disorders and was one of the co-authors of the 2017 ADA position statement on sleep-related breathing disorders that I often reference on this show, and we'll be talking much more about that during today's episode. Dr. Jerry Simmons is triple board certified by the American Board of Clinical Neurophysiology, American Board of Psychiatry and Neurology, and American Board of Sleep Medicine. He is the founding director of Comprehensive Sleep Medicine Associates with locations throughout Texas. Dr. Simmons is also the founding director of the Sleep Education Consortium, a nonprofit organization that focuses on enhancing the education of doctors and the community on sleep disorders. He has dedicated his career to providing the highest level of diagnostic testing to identify the full spectrum of sleep disorders, something you all know I am very big on and will talk more about during today's show. Dr. Simmons is among the few sleep specialists in the United States who can competently diagnose children who have hyperactivity attention deficit disorder caused by subtle sleep disturbances such as upper airway resistance syndrome or periodic leg movements of sleep. He is committed to teaching medical and dental professionals, as well as the general public, about sleep disorders. Doctors Carstensen and Simmons are truly leaders and pioneers in the area of sleep disorders, and the three of us have a fascinating discussion on all things sleep and airway that you do not want to miss. So without further ado, let's get on to today's episode. Enjoy the show, everybody. Welcome to the Doc Podcast, Steve and Jerry.
Yeah, welcome.
Thanks, Mike.
Thank you guys so much for coming on. I'm really excited. I know we've been talking about trying to coordinate our schedules and make this work for a while. You guys are so busy, and I really do appreciate you taking the time out of your crazy schedules to come on and talk to the audience about this and let them hear our discussion about a lot of the things we talk about behind the scenes that we want to spread that message out to the dental, medical, and lay public communities. Just to begin, I'd love to hear about how each of you became so interested and passionate in the sleep and airway arena. You've both, as I mentioned in the intros, devoted a ton of time and energy to this in your respective careers, and that doesn't just happen by accident. So, Jerry, maybe we can start with you and then go to Steve. How did you get so interested in the airway side of things, and why has that become your passion and your mission?
Well, I'm a neurologist and I'm interested in sleep, not just airway, just sleep as a whole. And what got me interested in sleep medicine was mainly the technology that was involved in evaluating the sleeping process. I went to medical school back in the 80s and PC computers were first coming out, and I got involved in some research using computers to analyze brain waves. And one thing led to another, and I started realizing that sleep medicine was an entity, but they weren't using computers. It was all on paper. And in my last year of medical school, I did a rotation, a 1-month rotation in the sleep lab, and this was at Ohio State University. And I was really fascinated. But then I went on and did my neurology residency at Washington University. And I learned so much about neurology, and I realized there was not much about sleep, and I just had a growing interest on it. So I decided to do a fellowship in sleep. And I ended up going to Stanford University to do my fellowship. And on my way, I remember very clearly thinking, okay, sleep apnea is sort of the bread and butter, and it's all about just the oxygen dropping. And that's sort of the basic, but there's all the other parts of sleep that I'm really interested in, about the brain and how it functions. But within the first few months of my fellowship, working with Chris Chung, EMNO, I realized how breathing is such a critical aspect of sleep and how disruptions of breathing can lead to disruptions of sleep, and that neurologic conditions such as ADHD, for example, can be due to disrupted sleep, and it may not be so robust where the oxygen drops. It can be very subtle. And I started learning more about the neuromuscular control of the airway. And so it's been a journey, but so I evolved my interest to become more entrenched in identifying the subtleties that are occurring that are leading to big problems. And at the time, dental sleep medicine was not very advanced at all. The first appliances were just coming out, boil and bites. So Dr. Mead had come up with this, which was work-free. And so I became faculty at UCLA and right away reached out to Dr. Glenn Clark, who had made some dental appliances, was involved. And he was impressed that I reached out to him. And I said, look, I need appliance therapy as part of my overall spectrum of things to do. So anyhow, I was evolving my knowledge and working with dentists and recognize that mandibular positioning influenced the airway in a very significant way. And not too many people were really paying attention to that. And I started recognizing that bruxing is actually a protective mechanism of the airway. And I was seeing this on sleep studies. So
about when is this now, Jerry? Like a general time frame?
This is the 90s.
90s. Okay, thanks.
When I was putting these concepts together, I met Dr. Rob Vies, who was actually teaching at USC at the time as a side activity, but he's part of Space Maintainers Laboratory that makes appliances. He actually is now the CEO of the company. But I started putting together educational material for him, for the dental community, putting together CE projects. But I just got more and more involved, and the more I worked with dentists, the more I learned. And I had also come up with something called the chin press tongue curl maneuver, which we do in the physical exam, and to actually bring out obstructive breathing at the bedside. And it's like, so a funny thing is that I wrote a grant when I was on faculty at UCLA back in 1997, I believe it was. It was a sleep education grant to the NIH, because the NIH was trying to fund more projects that were going to enhance the education of the healthcare community. Well, I put about a third of this grant effort was to educate dentists. And the reviewers had mixed feelings. Half the reviewers thought I was a genius, and the other half thought I was a misguided physician. And to spend more time focusing on physicians and not worry about dentists. Concept is that a dentist looks in the mouth of every one of their patients. And if they were looking at, they could be identifying so many of these patients that have sleep-related breathing disturbances. Well, here we are years later, and it's clear that dentistry plays a strong role, as we're going to touch base on throughout here. But anyhow, so it's been a growing interest and it's been exciting. And so, but I want to make it clear that it's not just about breathing. And I'm not only dealing with sleep-related breathing disorders. Narcolepsy is a big issue, restless leg, insomnia, parasomnias. So
yeah, it's so interesting because when you talk about that, I can hear your evolution in it. And it seems like for me on this journey as well, the more I start to learn about it, the more I realize how much I don't know. and how much more there is out there to learn about this. And you just said it's not just sleep-related breathing disorders. It started with this, not just OSA. There's these subtle disruptions that can have an impact and be significant. And then it's the coordination with other specialties and in the medical and dental arena, learning how to work with them. And then then there's these other parts of narcolepsy and restless legs. So it's just this huge umbrella that encompasses this sleep and airway arena. And I think that's probably one of the things that makes this so challenging for so many people to digest in their private practices. And we're going to come back to that. But because someone like yourself who lives, eats, sleeps, and breathes, no pun intended, it still is this huge, there's just so much out there. And I think that gets truthfully intimidating to your average wet-fingered dentist or orthodontist out there just trying to do right by their patients. So yeah, I appreciate you going into that, and we'll come back to a lot of those themes as you reference. So Steve, love to hear how you got into this side of things.
Like most things in my dental life, it flows through the Pankey Institute. I started studying down there in the late 1980s. And in my second episode at Pankey, the leader of the week's teaching was Dr. Keith Thornton. And Dr. Thornton was one of the early pioneers of dental appliances. He developed some of the first ones out there. His appliance called the TAP, the Thornton Adjustable.
Yep.
And so Keith and I bonded right away. It was one of those meetings where you meet somebody, you start talking to them, you realize this is going to be an important person for me for lots of reasons. And so Keith was my mentor in Pankey things, which is occlusion and function and jaw joints and all those things. And then also he was thinking about airway and appliances and dental rolls. And so he would call the people that were close to him, and I was one of those, and said, man, you got to do more of this. Man, you got to do more of this. And then right after that, for some reason, there was a conference here in Seattle. It wasn't an ASM conference. It wasn't at the time, Sleep Disorders Dental Society conference. It was just a conference that they decided to hold at Virginia Mason, one of our hospitals here, and with a sleep doctor named Ralph Pasquale, who is one of, and Dan Loeb, two early pioneers in Seattle. And so Keith said, well, you got to come to this. Of course I got to come to this. So the topic became part of my life. And as I learned more and more about it, I realized why it was so attractive to me is that it's all about physiology. Having way back in biology college days, anatomy and physiology and physics were my favorite courses I ever took, because of learning how things work and how they interact turned out to be just my wheelhouse. That's what I wanted to know more about. And as a dentist, then seeking to be a higher than average dentist, investing time, energy, and money, and going to places like Pankey Institute, then being introduced to this topic that involved whole body physiology was perfect for me. And thinking into that was a hobby. It was fun. It was interesting. It was challenging. It was all those things. Then also being an educator all my life, I was the kid in fourth grade that all the other kids came to and asked, well, what did the teacher, would you help me with? So as an educator then at Pankey and others, I realized that with the background I had and some other educational opportunities I've been given, I have this unique ability to blend Pankey and Pride Institute management and now sleep together. So I've been a teacher of this for a long time. So now going on 15, 16 years, that's all I've taught is about this. So the key there, I think, for dentists is that there's no simple case that we can just dismiss as all we have to do is this and we're done. But there are cases that can be managed without a ton of complexity. And there are cases that need a lot of oversight by a whole team of healthcare providers. And the key, I believe, for the future is going to be teaching how we can recognize the differences between those. Because some patients, I mean, if we hold the jaw forward and they breathe well, their physiology is back on track. And if we get the right kind of sign-offs on that, as it were, it's fairly easy for us not to. Man, that gives dentistry a chance to impact so many more of the people in the community that are suffering. But it's also dangerous to think that all we have to do is hold the mandible forward and that's going to solve everybody's problems. And that's being taught by too many people out there as well. And so running into Dr. Simmons, Jerry, I think we talked in St. Louis about how we met, but I can't quite remember.
I think it would have been in New Orleans when the oral facial pain Dr.
Yeah. Okay. So when I ran into Dr. Simmons, who is, as you just heard, so involved with keeping many people on the team for treating these people and recognizing whose expertise goes where and how we can all work together. And the early intervention by dentists is important as well. Not every sleep doctor thinks that way. And so Terry and I have gotten along very well for a long time because we have such parallel views of how we can manage patients and help relieve suffering in our communities.
Oh, thank you for both for going into that and explaining it. And the underlying theme, again, that you alluded to is this is really complicated. And there are dangers in the oversimplification of this, whether it's a marketing perspective or a sales perspective or a practice production perspective. Sometimes we can get lulled into this false sense of, well, I'm going to start to do some sleep and I'm going to start to do this. And it's just as easy as a enteral appliance or some sort of, or in the early treatment age, just some expansion. But it's so much more complicated than that. And we're going to try to distill as much of that down to simpler terms as we can throughout this show with you, the help of you two experts here. And that's why I'm so appreciative of you being here to shed some more light on this. And
as Steve pointed out, there's a spectrum of the types of presentations that these patients have. And just like anything, there's a learning curve.
Mm-hmm.
And if you get started, you can first tackle the more simplified cases and then take on, and as long as you have sort of people to refer to, collaborate with, to gain more knowledge and to grow your expertise with time, it can be transforming to your practice.
Mm-hmm.
But don't shy away from how complex it can be, because there are clearly a lot of patients that only need a very simplified solution, and it can be transforming to their lives.
Yeah, that's really well said. And I agree. Some people are just intimidated that I speak with. They're just intimidated to even get into any of this. From a liability perspective, from a time perspective, from a knowledge perspective, they don't want to touch it with a 10-foot pole. And there are other people who, to your point, and similar to what Steve was talking about, think they probably know more than they do and maybe oversimplifying it. So that's the key, and why it's so great that you both not only take the time to do this in your practices, but share this, because it's conversations like this, these type of conversations that we have at the meetings and that we discuss amongst ourselves, that a lot of the people who listen to this show are just trying to navigate this space. So I'm glad you mentioned that, as in, don't be intimidated to start exploring this arena. At the same time, realize that it is a complicated arena and you have to do your homework and do your research and talk to your colleagues and work with others to really put the pieces of this puzzle together. And when you do that, I can speak to it myself. It is literally the most rewarding thing you will ever do in your practice, when you truly change the lives of these patients and their families, which is really amazing. And on that note, we'll stay with you on this, Jerry.
Can I say something?
Yeah, sure. Please go ahead.
The slides I include in nearly every presentation that I give is a quote from my friend, Dr. Kevin Quishan, who said one time when we were speaking together, he said, "This is a thinking person's game." And I just love that. I told Kevin I'm going to use that every time I talk to anybody, because it really is. You have to be a thinking person to be able to find all the nuances, to consider the possibilities, to identify the opportunities that we have to intervene in this particular patient, but also to see where there may be something else that has to be addressed. And then we have to follow them. We're managing here. We're not giving them a solution and then walking away.
Mm-hmm.
That means we have to be able to recognize the signs. So that in this, another thing I put in all my talks is a list of resources. So if you're going to be a thinking person about managing airways, about dealing with the consequences of poor breathing, then you also have to be a student. You have to be curious. There's tons of resources out there. Jerry and I have both contributed to books. We've written tons of articles. We've been on podcasts. That's just us. And there's innumerable others that are our mentors that we've learned from, and people we've taught that have gone on and become teachers themselves. There's lots of resources. Somebody told me way back when, every day you think about airway, Steve, and airway at the time, every day you think about airway, open up the principles and practices of sleep medicine and learn something. Read a page, read a chapter, read a paragraph, learn something new every day. And now with all the resources we have, it's not just principles and practices, but the key is, if you're going to treat a condition that involves the whole body physiology, and you're going to work with colleagues to knit this all together, you have to be curious, you have to be a thinker, and you have to be able to find resources and learn something new every day.
Yeah. And as I made, the underlying theme of my talk in St. Louis was, you have to care. This requires a lot more time and energy and effort in the patient intake process, in the diagnostic process, in the treatment planning process, in the treatment delivery process, and as you said, Steve, in the follow-up process. This is not a quick fill it, bill it, service, straighten the teeth, throw them some Invisalign aligners, get through the treatments as quickly as you can. This is much more involved and in depth. And I do think that also is something, to Jerry's point, that starts to intimidate people a little bit, because they start to open up this box, so to speak, of this sleep airway arena and realize that we haven't been taught a lot of this. And that's the next point I want to get to, is why. Coming to you first on this, Jerry, why the societal problem of sleep disorders in general, I feel like the public is not super educated on, right? Parents, I mean, how many parents really understand how their children are supposed to sleep? How many parents understand how they're supposed to sleep? And how many healthcare professionals, dentists and physicians, really understand this and understand what the importance of it is? And then to the next level, how to even detect it in their patients. So why do you think that is? And I know you're working on some things to help with that, but just, I'd love to hear you talk a little bit more about that.
Well, if you look at the epidemiology, probably about a third of our society has some type of a sleep disorder, if not higher. And whether it's an occasional or chronic condition, but it affects, millions and millions of Americans, okay, and worldwide, way beyond that. If you look at medical school education, the last survey that I saw published was from 2018. And on average, there was about 2.5 to 4 hours of time spent over the 4 years of medical education teaching anything on sleep, whether that's normal sleep physiology or sleep pathology. Right. So here you've got a physiologic process that we spend a third of our lives doing, which is sleep. And you have so many conditions that can disrupt sleep that can affect such a large percentage of the population, but there's so little time spent teaching medical students anything on this topic. So it's really a lack of knowledge. Now, if you look at the field of sleep medicine, it's in its infancy. You look at other fields of medicine like cardiology, gastroenterology, pulmonary. I mean, they go way back. They've been around for, long time, over 100 years in some of these specialties. Sleep is only recognized as a specialty within the American Medical Association. Only recognized it, I think it was like 2006 was when they finally recognized that it's a specialty, right? So it's in its infancy. Now, I went to Washington University Neurology Fellowship Program. It was one of the highly regarded top neurology residencies in the country. I was the first resident to finish that program, which was in 1990. That went on to do a fellowship in sleep. And I didn't do it there at Washington University because I didn't have anything. I went off to Stanford. And all my colleagues were looking at me like, what are you doing? I go, I'm going to do a fellowship in sleep. And it was crazy. They hadn't heard of it. It was like, who does that? I go, well, I do. Well, actually, so my junior resident, Steve Duntley, thought, well, that's really cool. Wow. So Steve Duntley went on to do a fellowship in sleep also a couple of years later when he finished the residency. He went back to WashU and developed a humongous sleep program. And it's now a highly regarded sleep disorder center in the country. But the point is that it's all new because here in 1990, there were only 2 or 3 fellowship programs in the country. All right. Now there are many, but a lot of those fellowships were being filled by pulmonologists and they were added onto their pulmonary fellowship, just do a little bit of time in sleep. And now they now they have to do a dedicated full year. But the thing is that there's just a lack of education. And as a result of that, people don't know. And people are not getting diagnosed. And when people bring the problems to their physician, the physicians are not coming up with satisfactory solutions. And so it's just the blind leading the blind, so to speak. So I'll try to address this. I was on faculty at UCLA for a number of years. And then I left, come out to Texas and recruited to come out here to open up a practice back in 1999, but I still wanted to educate. And I started a nonprofit organization, the Sleep Education Consortium. And the mission statement of this organization is to enhance the education of the healthcare community. And we've been doing annual conferences since 2004, where we bring both dentists and physicians and other healthcare professionals together to learn about sleep disorders, to try to fill the void in their training. And this has enhanced over the years. And now actually we're getting ready to do our 21st year of this annual conference.
Wow.
To physicians and dentists.
Where and when is it going to be?
For dentists, it's April 3rd, 4th, and 5th.
Okay.
And
of this year, of 2025.
Correct. Okay. And for physicians, it's April 4th and 5th, because we have an extra day for dentists where they learn how to do the oral exam, where they learn about oral appliances. They work with them and they learn how to do a registration bite and learn how to screen. And so the first day is primarily a dental day. And then the next 2 days are for physicians and dentists in the same lecture room, learning about all these other aspects of sleep and orthodontics and how it plays a role, oral surgery. But they learn about insomnia, restless leg syndrome, narcolepsy, parasomnias. And so why does a dentist need to learn that? Well, they're not going to manage those conditions, but they need to be somewhat knowledgeable, because when you start talking about sleep to your patient, it's like opening up a can of worms. And to increase your credibility as a dentist with the patient, to have some understanding, it helps the patient feel more comfortable. The dentist is not just trying to sell a widget. The dentist really understands. So if you're going to get into the field of sleep, you really should feel obligated to take at least an hour lecture on narcolepsy, at least, because you're going to have I guarantee any dentist out there over the course of their practice is going to have a couple narcolepsy patients going through the practice, probably unrecognized narcolepsy. I've gotten a lot of referrals of patients from dentists that ultimately we find out that they have narcolepsy. That's why they're still sleepy. That's why the dental appliance or any treatment of their airway isn't resolving their sleepiness, because they also have narcolepsy or idiopathic hypersomnia. But, for the dentist to learn about these other conditions, restless legs, sometimes the patient is on their chair and they can't hold their legs still. It's clear that the patient restless legs, they're rubbing their legs. They're uncomfortable sitting still. And so it adds to the credibility of the dentist, not that they're going to manage those, but they could then start to guide the patient. And physicians also, they're naive. So unfortunately, the dentist can spend all this time educating their patient. And the patient is like saying, why is my dentist telling me all these things that my physicians never told me? Then they try to validate that information and going back to their primary care doctor and start explaining what the dentist said, and the physician will discredit it, say, whatever. And it's a shame. So at this consortium, we give the dentists and all the attendees the tools they need to enhance their practice. So for someone that doesn't know anything, this is a great conference to fill that gap, to bring you into this realm where you could start learning more about sleep medicine and sleep dentistry. And for physicians, it's transforming for them as well, to learn out that sleep may actually be behind fibromyalgia, maybe behind chronic migraine, maybe behind ADHD. These third of these kids, if not more, that have been diagnosed with ADHD and just given stimulants, it's an airway problem. You got malocclusions, small mouths, they're working harder to breathe at night, and it's fragmenting the continuity of their sleep. Their oxygen may not drop. You can't use an oximeter to screen them. It's more subtle. But if you open up their airway and treat them correctly, then they can get away from these stimulant medications. I cover some of this on my TED Talk, which is a 16-minute encapsulation.
I'll put a link to that in the show notes. And if you can, people who are listening on audio, I'll put a link to some more information, overlay it in the video when I go to production with this, so they can see a link to the conference information as well. And I'll put that in the show notes as well. And I love that you're getting the physicians and the dentists in the same room, because I faced that in my practice all the time. I would recognize these issues. This is going back over a decade ago. I would start detecting some of these issues of pediatric sleep disordered breathing and airway issues. And especially when I got my CBCT in 2014, and I would go to the physician, and I've told this story before to people, but I'd go to the physician, to their pediatrician, and say, hey, I've seen this, I'm detecting this. And first of all, a lot of them wouldn't even return my call, I hate to say, and I knew these people in my community. They were just so busy. And then they would call and they're like, I'm looking, they haven't had strep more than 5 times. I really don't know why you're even really wasting my time with this. And it happened time and time again. And I was on the cleft craniofacial team as an orthodontist. And that's when I started picking the brains of the team members, especially the ENTs. And then my next door neighbor was also my allergist. I started picking his brain, and they were just like, Mike, just send them right to me. Just direct send them to me. And I thought, okay. And I did that, and it worked great. But I always thought, man, is that sad. Like, I have to bypass the primary care physician in all of this, who should be really the one that's really helping me recognize this and facilitating these discussions. And they didn't want to have any part of this discussion. So I'm so glad to hear that with the consortium, we're trying to bring together the medical and the dental community on this and help the dentists understand why they need to understand and be competent in some of these areas that they may not realize, and the physicians as well.
Right. Let me throw it out there real quick for those who are just hearing this. The webpage for the conference, it's easy to remember. It's dentalsleepconference.com.
Dentalsleepconference.com.
All one word, dentalsleepconference.com. So obviously I've been doing this for a while that I was able to get that URL.
Yeah, seriously,
right?
That's a good one.
And then also for the physicians, it's medicalsleepconference.com.
Okay.
It's the same for the dentist. They'll go to the dental one, and it's for the 3-day registration.
That's great. I appreciate you explaining that. And then to Steve, to you on that, what's been your experience from the dental side on this in your journey? How has it evolved? And why do you think there is such a lack of education in the dental arena in our schooling system and process, as well as lack of coordination with our medical colleagues?
Well, certainly I can't speak for every dental school, but I can tell you that many people ask me, well, when is this going to be taught in dental school? And as I was surveyed around to a handful, or I get a chance to ask a dean or some leader in academia, what about sleep in your school? They'll almost always say the same thing. Oh, we don't have time in our curriculum for this, which means they don't have priority in their curriculum for that,
Yeah.
which means that they choose to spend their time on some of the other things. And it's been so long since I've been in dental school that I can't really quite remember all the wasted time. I distinctly remember coming to the end of one course of, I think it was oral pathology, where we actually rose up in arms at our final lecture because they had made us buy a book and they never assigned anything out of the book. And it was just it seemed like a whole waste of a quarter. And I think, gosh, couldn't we? And now, of course, I had no perspective then, but now I think, what is in modern dentistry that could be part of a dental school curriculum? And as I've talked to some of my successful colleagues around the country, they have been able to offer an elective course here or a lecture there about sleep, but it's never integrated into the curriculum. I talked to friends that are primary care physicians, and they say, well, we didn't learn anything about sleep in medical school, and they haven't had time to take extra classes. And so when they tell me that they're frustrated because they don't know how to answer the questions the patients are asking them, they do see some signs of sleep. The patients say, well, I don't want a CPAP, and so I don't want to go get a test. And after being told that enough number of times, then the primary care doctors just don't bring it up. And so even if they know a little bit about something, the next step seems to be such a barrier that they don't bring it up. So in dentistry, as a dentist, you're out there, you're trying to make a living, you're trying to solve the problems that your patients are presenting. And to introduce something new that takes time takes a commitment. And if you go to a course, a lecture at Rocky Mountain Dental Conference last weekend, so maybe somebody new was in that room and they'd go away thinking about it a little bit and recognize some troubles in their patients, and they go, I'm going to learn more about this, because I certainly didn't give them a comprehensive way of doing things last weekend. But if I spark their curiosity, and they're back to that again, then they're going to learn what they have to learn. But in dental schools, there's beginning to be a few programs where they're able to add this in. UOP in California, I know, is doing some of this. And Carolina, I think, has some of this going on. But it's not enough. It'll get there, but it's a slow rise to that point. And then we do have limitations in our communities as well, because the dentist gets all excited about this, and like Jerry's point or your point, sends the patients back to the primary care who doesn't know anything about it because they're doing other things. And then one of the resources I've read over the years is about adult learning. And one of the things that they bring up over and over again is pattern recognition. Because it's true in our brains that when we see patterns, we recognize those patterns and we see them everywhere, right? We all know that when we're interested in a new car, we see that car everywhere. And so physicians are no different. They're humans too. And so they see a kid come through with the same behaviors the last 100 kids have come through with, and they put them in a category. People come through with hypertension, and they've been told, and they've seen the research about antihypertensives and so on. They go to the medications. They don't consider they don't broad brush painting here. It's pretty easy to conceive of a busy physician not having the time to be curious about the upstream etiologies. Let me treat the symptoms here and move on. And make people happier. They feel better. They don't have the headaches. They don't have whatever the courses of problems that they're having. But they don't think about how they got that way. And Jerry pointed out earlier that bruxism, for example, something that dentists are trained to treat with what? Night guards? Without thinking about why they're bruxing. And Jerry says they learned early on that, well, that's could be a response to a breathing problem. Nobody ever mentioned airway or breathing issues or sleep issues or any fragmented sleep, any of those things when I was in dental school. And of course, that was a long time ago. I don't think they're even being mentioned last week in dental school either.
No. And if I may, a little quick story to both of your points on that. I was teaching overseeing a case with one of the residents, and it was a case that I hadn't started with them. The faculty member that had it is no longer there, so it transferred to me. Invisalign patient, young 20s female, nursing student. She comes in and we're trying to open her deep bite and it's not working. And I've done a lot of Invisalign, plastic aligners, and clear aligners in my day. I know how to open deep bites and it's not working. So then I start looking at her aligners and I'm noticing, and now remember, you would change the aligners weekly. She's had this one in for 5 days and she had already perforated the incisors on this. Think of the stress she's putting to generate that amount of wear in 5 days on these aligners. So I sat her up and I said, can I ask you a couple questions about your sleep? Now, again, to your point, because there is nothing in our education about this, because there is no screening tool, and we're going to come to that in a moment with the ADA 2017 statement that you were involved in, Steve, and the need to screen, right? And which the AAO in their white paper, there's a lot of things in the white paper I don't care for, but it does say clearly multiple times that we are required to screen these patients, but we don't. And to your point, Steve, it's time a lot of times, right? We just don't have the time to learn it, to do it, to implement it. So I sat her up, I asked her, I said, can I ask about your sleep? She said, yeah. I said, has anyone ever told you snore? And she's like, yeah, it's funny you said that. Like, people have been telling my significant other, my boyfriend told me recently, like, I'm snoring really loudly. And I said, are you often fatigued during the day? I know you're a nursing student and it's intense, but you feel like you're like more tired than you should be. She said, I'm exhausted all the time. And I said, in the morning, waking up, is it difficult? Yes. And I started asking her some more of those in-depth questions. And I said, you have a breathing problem. And I'm confident that the bruxing is a sign of that and a symptom of that. And we need to get you to, and we're very fortunate to have someone like Stanley Liu at our facility. So we need to get you to a sleep professional who can start to figure out what's going on with your airway and your sleep, because the reason your teeth aren't moving properly is because you're clenching and grinding so hard, you are overwhelming the force of that plastic. There is no plastic or probably even metal out there that we could put in your mouth that's going to let me overcome the orofacial musculature at this point based on the severity. And it was a great learning opportunity for the resident too, to see when you do spend that time, when you do look into it. Jerry was referencing with the restless leg in the chair, right? Look at your patient a little more than just, man, why is that deep bite still hanging around? Or why are they kicking their leg in the chair? Take that time. And both of you have mentioned that word multiple times. And that is so important that we have to take the time to focus on this. So with that, I actually want to start back with Jerry and then come to Steve about the 2017 position statement that Steve was involved in. But speaking generally about that, Jerry, you had referenced, and Steve, the spectrum of disease that is sleep disordered breathing, and that it is not just all obstructive sleep apnea. So I want to start with you on that, in what you think, how can you distill it down into terms that the average practitioner out there, whether they be medical, dental, or maybe even layperson, can comprehend, and what you mean by this is a spectrum, and what some of those things we can recognize would be. And I know it's a huge list, so you don't have to get too granular on it, but just generally speaking. And then we'll go to Steve on that and talk about how they incorporated those concepts so beautifully into the 2017 position statement.
Well, a lot of people try to differentiate into sleep-related breathing disorders or sleep disordered breathing and sleep apnea. They're not distinctions of each other. But when you look at sleep-related breathing disorders, the big category are obstructive sleep-related breathing disorders. There are other that are like central sleep apnea or alveolar or hypoventilation during sleep. Those are rare. Put those aside. So all of the remainder where you have are obstructive breathing disturbances during sleep. All right.
Mhm.
So let's talk about that just for a minute. I'll say it the way I tell my patients. Okay. And there's like a 1 minute or maybe a minute and a half Reader's Digest version of sleep apnea.
Mhm.
So when you breathe, air rushes through your nose, your mouth, and rushes through the back of your throat. As air flows through the back of your throat, it creates a negative pressure. Whenever you have any kind of flow going through any kind of space, you get a negative pressure. There's a term for this. It's called the Bernoulli effect. An example that people can relate to would be in a shower. When you turn on, the water flows. As the water is flowing, the shower curtain may pull in towards the water. The shower curtain's pulling in towards the water because of the vacuum created from the flow. If you try to get the same amount of flow to a smaller space, you get a stronger vacuum. All right. And if you have the same amount of flow to a larger space, there's less of a vacuum. That's why the shower curtains now bow outward to open up that space to decrease the likelihood of them pulling in. So those same principles apply in the back of your throat. So your tongue attaches right here in your mandible, right behind your chin. Okay. And then it goes to the back of your throat and goes forwards. That's your tongue. So imagine this is your tongue. All right. Attaches to your chin, goes to the back of your throat and goes forward. And then there's the back of your throat. So when you breathe, air is rushing through this space. When you fall asleep, the muscles relax, the jaw may fall back, and the space becomes more narrow. So now if you're getting the same amount of air through this smaller space, you're going to get a stronger vacuum. At a certain point, the vacuum's strong enough that if you have a lot of tissue there, the tissue starts to flop around and vibrate in that space, and that's what causes snoring. Snoring right away lets you know that there's an increased degree of negative pressure in the back of your airway. It's a side effect of the negative pressure. Now, it depends on how much pressure, and it also depends on how much tissue. So some people will start snoring at a lower degree of negative pressure because they've got a lot of tissue. Other people, it takes a higher degree of negative pressure before they start to snore, right? At a certain point, the vacuum is so strong that the airway will completely collapse. At that point, a person's asleep, they're trying to breathe, but they can't. And as a result, the brain says, hey, you're not breathing, wake up. There'll be a brief awakening. With the awakening, the airway opens up and breathing starts up again. And once breathing starts up again, the brain recognizes that things are better and they go right back to sleep. So there's a brief disruption that occurs in sleep. That can occur repetitively throughout the night. Now, what I just described is complete obstructive sleep apnea with a complete blockage of the airway. Put that on one end of the spectrum. Normal breathing on the other end of the spectrum, and realize that there's a lot of things in between. So there are instances where the airway is partially blocked. A person's working a little bit harder to breathe. There's a little bit of obstruction. There's more negative pressure. And then the brain could realize, oh, the person's working. They're realizing that, oh, I have to work harder to breathe. And the brain says, hey, wake up. With the awakening, the airway opens up and now it's easier to breathe. So the point being is you don't have to have a complete blockage. You can just have a partial blockage. Now, when you have a partial blockage, in some instances, the oxygen may drop, but in others, it may not. So if you're having a partial blockage and your brain realizes it's happening, it will then have this brief awakening to open up the airway to start the breathing again, all right? So there's different degrees. So there's various spectrums all the way to the point where there's no blockage, all right? So there's a spectrum, all right? And that's the spectrum of obstructive sleep apnea. Now, our tools to measure this there are various types of tools. Now, when someone's on the point of the spectrum where there's a complete blockage and the oxygen drops, that's easy to diagnose. But when you're in this other part of the spectrum where it's only partially blocked, it becomes more difficult. And then if you're at the point where it's just slightly blocking, but it's still enough to cause awakenings that can get missed by even routine sleep studies. So in some instances, we actually have to add extra parameters to measure that negative pressure with a thin little catheter to measure these respiratory effort-related arousals that can disrupt sleep. So sleep-related breathing disturbances are in a spectrum of degree of severity. All right. Now, this is what makes it complicated, is everybody's brain is different. All right. Just like everybody's overall metabolism is different. You could take two people and give them the same steak and potatoes meal 3 times a week. One person is going to have a high cholesterol as a result. The other person's cholesterol is going to be just fine because their metabolism is different. Well, within the brain, everyone has a certain degree of susceptibility to how much fragmented sleep they can withstand before they start having symptoms. For some people, their nervous system is very sensitive. If you fragment their sleep a little bit, they're going to be devastated the next day. So those individuals are going to be symptomatic with those real mild obstructive respiratory events. And they may have what some people call the upper airway resistance syndrome, all right, which is a very subtle form of obstructive breathing during sleep. The same degree of obstructive breathing may occur in another individual whose nervous system is more resistant to feeling the ill effects of the fragmented sleep, and they have no symptoms whatsoever. So it's not just a matter of the test results, it's a matter of the test results in the context of what's going on with the patient clinically, all right? So you have to put these two things together. But if someone is symptomatic, their breathing could be anywhere along that spectrum, all right? And if you do a home sleep test, it may be very easy to pick up if they're on the severe side of the spectrum, but it's going to get missed if it's in the more subtle form of the spectrum, but the person's symptomatic. So you cannot exclude sleep apnea as a diagnosis with these home sleep testing devices or with oximetry at night, because oximetry is not the defining factor of obstructive sleep apnea, all right? Otherwise, we would call it desaturation apnea. They would call it.
Yep.
Right. So if someone has a normal home study and they have symptoms, then they need to go into a lab. And the lab, but not all labs are going to be following the same scoring rules. And it gets to really a little bit more complex, and we don't have time to really go into all of it. And again, I encourage people, go to this conference. You will learn. It will open up your understanding of this area. And you'll know also how to critique the sleep centers you're sending your patients to, because not all of them are doing things the same way. But anyhow, there's a spectrum. So when some people say, oh, there's obstructive sleep apnea, and then there's sleep-related breathing disturbances, they're on the same spectrum, they're just different points. And there's a lot of literature that's been published and peer-reviewed that I think is flawed, because they're throwing them into two different bins. It's all because you may start off with this more subtle sleep-related breathing disturbances, which is mild obstructive sleep apnea, maybe in the form of the upper airway resistance syndrome. And over time, it will progress to becoming clear-cut sleep apnea. And if you wait to the point where the person's oxygen's dropping and they're having complete pauses in breathing, you miss the boat. You could have that person's life at a much earlier point of this pathologic progression if you just knew what to look for and an implementation was given. And that intervention can even occur in little kids, even as young as 3, 4, 5 years old. And I'll leave it at that. I'll let that transition to our next topic.
Well, wasn't that the perfect segue into what we're going to get to in Steve here and the dental side and what we can do? And thank you for explaining that so clearly and succinctly. That was, I honestly, people, please go back and replay that, whatever that was, 3-4 minutes that Jerry just took to explain that, because that was a lot of what I was trying to convey. And you did it, I think, better in a few minutes than I did in 45 in my talk in St. Louis. But that was a lot of the message I was trying to get across. Is it is a spectrum of disease, and we can play a role as the dental professionals in detecting the early signs and symptoms and comorbidities of this disease to try to prevent the very progression that Jerry just outlined, to where you said we missed the boat. Now these people are completely obstructive, and now you're trying to basically treat the symptoms and the somewhat catastrophic situation that you're in with this patient in a very compromised state. And to Steve, that is one of the things I love. And when I speak on this and on my show, I contrast the 2017 ADA position statement with the 2019 AAO white paper. And one of the things that I often say on this is people say like, oh, you're so hard on the white paper. I'm just being honest in the fact that it focuses on end stage disease. It focuses on obstructive sleep apnea. I mean, that is in the title of the actual white paper is obstructive sleep apnea and orthodontics. So that was the focus of that document. And I really think that's flawed. And I've called on the AAO to do a better job to address the very spectrum that Jerry just outlined and the role that the dentist can play in detecting and intercepting these problems.
So, like, let me just intervene one thing. Let's call all of that obstructive sleep apnea syndrome. And the reason why is because sleep apnea doesn't need to be a pause in breathing during sleep. It could be what we call hypopnea, a partial blockage. And that's why when we look at the index, the apnea hypopnea index, which is the frequency of these events per hour of sleep, they combine apneas and hypopneas together for that index, right? Because hypopneas are much more frequent than apneas, much more. And so when you're really trying to address this condition, all of the obstructive sleep apnea syndrome consists of all of these different levels of obstructive breathing, including the upper airway resistance syndrome.
And then where would you put snoring on that?
Snoring is the byproduct of the negative pressure. So it's commonly occurring with these obstructive respiratory events. So if someone has negative pressure to the point where they snore, and that point may be very low for them, meaning they have a lot of extra tissue. So it doesn't take much negative pressure. They're not having fragmentation of their sleep, this long, persistent snoring. They have no hypertension, no daytime sleepiness, no sleep bruxism, no morning headaches. There are no negative ramifications from this obnoxious sound that's occurring. Then it's benign snoring. Now, you can't make that determination on your own by a history. You're going to want to do a sleep study. And that's where a home test can be useful to rule out what I call occult sleep apnea. You don't care about the mild fragmentations that may occur if the person has no symptoms whatsoever. You just do this test to make sure that in REM sleep, when all their muscles are paralyzed, that they're not going into bad apnea and their oxygen's dropping down into the 80s on those occasions, because then it's not benign snoring. But the patient may just have benign snoring. But snoring coexists with obstruction, and that's why there's this big overlap. Snoring alone does not mean you have sleep apnea, but many snorers do have obstructive sleep apnea.
And is that the same with children?
The children should not snore. Okay. If a child snores, that's a big red flag. There's something wrong. It should just not occur in a child.
Okay. All right.
And if that's your starting point, snoring as a child, think where you're going to be 10 years from now, 15 years, 20. I mean, so if the child is a mouth breather, those are red flags, snores. Now, if they're snoring only when they're congested and it happens 2 or 3 times a year, okay, fine. But if it's a chronic phenomena, when you start off with your pediatrician or your dentist, and if they say, oh, don't worry, they'll grow out of it, find somewhere else.
Yeah, thank you.
Oh, there's so much I could say here, Jerry.
Well, go take it, Stephen. If you can tie in 2017 statement into what you're going to talk about, let's hear it.
Too, and I am very happy to say, I'll point out, let's say, that the 2017 policy statement was not about obstructive sleep apnea. It was about the dentist's role in treating sleep-related breathing disorders. And so they included in their label all of the orders. They didn't limit it. Now, that being said, the ADA has a section of their codes, and it's called sleep apnea. So that it's an evolving understanding of the roles and the fact of the spectrum, as opposed to the limitation of the obstructive sleep apnea label. If we look through the policy statement, which was the first policy statement by the ADA that included medical information, it gave us a role to play in identifying people at risk, because there's so many people out there and not enough people are looking for it. And if we can find it and direct them to a proper diagnosis with our medical colleagues, now we would again play a role in helping relieve that suffering in our population. There's 11 paragraphs after an introductory statement, and 10 of those paragraphs are about the cooperation between dentists and physicians in managing these disorders. One paragraph is the most powerful, I think, of the statement that ADA has made in decades, and that is about children, because it puts on us the role of identifying kids at risk for breathing problems, because they recognize when they were putting the policy statement together that dentistry is the part of healthcare that pays attention to growth and development of the oral-facial complex. And we were taught in dental school to look at where the teeth are coming in and how we're going to line those up and how's the bite going to work and the jaw joint coordination and all those things. But what we're realizing, and certainly the message I'm trying to push out there, it's not about where the teeth are. And the teeth, we want to get a good smile. We want to get a great occlusion. We certainly want the jaw joints to function well. But what we really want is the bone that supports all that to be in the right place. because when that bone supports the things we can see, the teeth, the handles, the labels, the visual portions, when those parts are aligned correctly, they also support the airway. And if we develop the proper airway support with good bone positioning, growth, development, AP position, all those things, now we also set that child up for lifetime. I got into thinking about kids' airway as I was treating all these 40, 50, 60, 70-year-olds in my practice. And I'm wondering, what were they like when they were 4, 5, 6, and 7? I mentioned Dr. Thornton, my mentor. Well, he treats adults. I treated adults in my practice, but I ran into powerful thought leaders like Kevin Boyd, who said, no, it's about the kids. And so I started listening and being curious and wanting to know what happened to how those adults got that way. And my own mouth is that way too, is that, wow, when those adults were little kids, nobody knew to think about that. So how we can change it? And the last sentence of the policy statement in paragraph in the point number 2 says, help the child to develop an optimal and physiologic breathing and growth pattern. Well, how could that be more appealing? And so as we consider what we can do in kids to make sure they don't grow up with that compromise, that extra tissue, that tissue that allows the oral pharynx to be subject to that negative pressure that Jerry was talking about, then where do we put the bone to make sure that doesn't happen? A big factor of this is nasal breathing. So the body here feels how it breathes through the nose. It doesn't feel how it breathes through the mouth. There are specialized neural signals coming from the nose, the mucous tissues in the nose, specialized cilia, that tell the autonomic nervous system that air is moving back and forth. And if you don't, and so that's part of how it detects that fast moving air, that negative pressure, and changes the autonomic nervous system to balance that out. If we don't breathe well through our noses, then we don't send the brain the right signals. Well, who can take care of that? If you have a congestion, if you have an allergy, if you have something like this, you go to the ENT or the primary care doctor and get some medicine. But what started that is structure again. If the palate's in the wrong place, if the maxilla is in the wrong place, then the nasal cavity is not formed correctly, and we end up with too much negative pressure in the nose as well. In the oral pharynx, like Jerry pointed out, so and illustrated so clear. Jerry, I'm going to use that hand thing that you were doing with your hand. That was wonderful. I didn't thought to do that.
This
For those,
from Chris Young, GMO.
Is that right?
For the first 2 weeks of my fellowship, he would explain this, and I'm like, oh wow.
I've been doing this for 28 years, and that's the first I've seen that, and it'll be there for the next 28 years.
Yes. So, excuse me, for those who are on audio, go watch the part where Jerry did that and talked about that, because I was thinking the same thing watching. I'm like, wow, that just really simplified that.
But in the nose, if you don't breathe well through your nose, then that negative pressure that's in your oral pharynx from breathing ends up changing the size and shape of the tissues in the nose. ENT Dr. Stupak did some elegant experiments showing that. And so if we have a patient who chronically mouth breathes, not only is the maxilla misshapen through the growth years, but also those bad habits end up with a poor nasal breathing function and certainly a poor breathing habit. And when we add all that up, we end up with a restricted breathing situation. And again, like Jerry pointed out, we don't know how anybody's going to respond to that. There are plenty of people with a small oropharynx, a small nose, and bad habits, and they have a very resistive physiology. They grow up and they have minimal troubles with that. Other people have marginal changes, and they have a big impact on their physiology. And one of the things we learned at Pankey Institute, that Dr. Pankey taught us years ago, is to get to know our patients and understand what their lives are like. So one thing you said, Jerry, I'm going to disagree on. Snoring, you said, benign snoring has no particular...
Well, I mean, there is a neuropathy that can actually, from the trauma of those...
We're not going to talk about physiologic problems. We're going to talk about lifestyle and social problems.
Right?
Because even the benign snorer who's having no sleep fragmentation, it wakes up with energy, who doesn't have any oxygen drop, all those kind of things, they have a problem in their lives. And I think there's many physicians who don't consider enough the social problems that people have with these bad breathing episodes.
Mhm.
If you're waking up with a headache every day, that impacts your partner. If you're snoring through the nighttime and you can't share a bedroom, or you're embarrassed to go on a trip with friends because of snoring, that's a problem in your life. And so I think that we have to include social issues along with physiologic changes as we consider the importance of reducing suffering in our community.
Yeah, and thank you for saying that. And in children as well, right? I mean, these kids won't go on sleepovers. A lot of these kids are growing in a way that is abnormal, and abnormalities are picked on and picked apart by peer groups. And so these kids, we've been told in orthodontics all this time, oh, wait, the ugly duckling stage of when they lose those teeth and it's normal. And we just accept it. Well, some of the people that I find that are the biggest advocates of being more proactive on early treatment are the ones that saw this happen in their own children or maybe own grandchildren, as the case may be, and thought, well, I can do something about this. Why am I just chalking this up to this is just the way it is? And the other thing I want to, so many things, but two things I'm going to highlight. One, when I was talking a little bit about the contrast in the AAO versus the ADA in those respective position statements, the AAO really has made it about, and even most recently at their meeting, in their winter meeting, the title was about the diagnosis and treatment of obstructive sleep apnea. And they're basing it all around this AHI, which I know this is very different in adults and children, but as Jerry just spoke about, in children, there's a lot of variability in that area. And that is the end all be all. And all, if you look at these studies, it's, well, this patient started pre-treatment with an AHI of 1.12 average. And then after expansion, it was 1.08. So it's not a clinically significant change. And what I want to try to call out and shed some light on is, as you both have been talking about, number one, it's much more complicated than that to just look at this isolated one night test in a sleep lab for a child. Number two, okay, say it didn't change their AHI, but now they're maybe having a greater quality of life and they're not responding the same way to the obstruction that they're experiencing. So it can be much more nuanced than that is my point. And I think to distill it down and to just try to make it all about this diagnosis and treatment of someone who registers with polysomnography on the apnea hypopnea index can be flawed, and in children specifically. The other part of that that you were going into, Steve, is when you look at the impact that this has on these children's lives. A lot of people in my profession feel, and I face this a lot, they say to me, I've had someone say to me on social media groups in the orthodontic arena, the etiology is genetics. Hard stop. There's a mom and a dad, and that's it. There's no influence of environment. Now, I can provide and have provided lots of research to these individuals to substantiate why that's a false statement. But I would like to hear your thoughts, staying with you, Steve, and then Jerry, on how this can be more than just genetics.
Well, I think it's distilled down to the simplification of the goals. Orthodontists, in my view, are, and certainly it was true when I was in school, are trained to pay attention to the smile, the bite, some to the jaw joints, and they stop there. They don't think about airway function. Again, not just airway size, not just some simple measurement, but how it behaves, how it works. There's been lots of studies, like you said, that have a lot of basis for what we can use to judge whether there's something good. There's a famous study, the CHAT study, Children's Airway Study, where they followed these kids and they didn't really see a lot of changes in AHI. That wasn't the outcome that they saw. But what they saw was changes in executive function. They saw changes in behavior. We think about little kids growing up and what's shaping their world. Is it their physiology, or is it how they interact with their family, their parents, the kids at school? Like you mentioned, do they have physical characteristics that are getting pointed at? I mean, all of these things have a psychological toll that they take on these kids. And when you're a child and you're learning how to work in the world, and you're singled out, you can't behave well, those kind of things, then you get labeled. And when you get labeled, then you get further labeled and further isolated. And that's not going to be a healthy adult in lots of ways. And so if we can intervene early and help that child manage their way through these difficult growth years, then think of the human that we're helping to shape. All parents want their kids to be able to navigate their world in the easiest way possible, in the most growth-oriented way possible, taking advantage of every opportunity they get. And if you set them back by not allowing them to enter their day prepared for the day, then day after day, what kind of toll does that take?
Mm-hmm.
But that's really hard to measure, isn't it? It's really hard to quantify and say, okay, here's a measurement of willingness to play with your friends.
Mm-hmm.
How do you do that? And then you intervene. And if you're really intent on not finding a way to change how you practice, then it's easy to point to, well, I can't measure that, so I can't do it.
Mm-hmm.
Or this measurement didn't make any difference, and so that means that the treatment didn't make any difference. Well, that's not how chat came out. That's not how many other research papers like you talked about might have come out, that we have to measure things differently for the little kids.
Mm-hmm.
So, Jerry, and you can speak to this. I'm curious your position on this one, but in my community up here, I see a lot of physicians who want to really apply adult PSG rules, adult sleep apnea assessment rules to 4-year-olds. And I just don't think it's valid. And you know what?
No, there's a different scoring principles they use and also different thresholds. In an infant, you don't have to wait 10 seconds to have considered to be a significant respiratory event. It could be if it's misses 2 breaths, because if you're at a faster respiratory rate and children breathe faster, if they then have an event that lasts 2 respiratory cycles based on their respiratory rate, and then they have, let's say, a neurausal or disruption, then it's significant. You don't have to wait 10 seconds. And then the frequency of the events are much lower. So some people say 1.5, some people say 2 events per hour is the low end of becoming significant. The thing is, there's a lot of other events that are going under the radar that we're not picking up. So when you have 1 or 2 events per hour that you are picking up, there are probably many more that we're not. But, a lot of our understanding is really deficient at the moment because we don't have good tools for actually assessing and identifying these kids early on. And it goes back to our deficiencies in the education of our healthcare system. So one of the things from that position statement that occurred, and that really Steve deserves all of the credit really to make the transition, was that he said to the ADA, look, you're asking these dentists to do things, but you're not providing them the tools or the pathway to be able to do what you're saying they should do. And I'll let him speak in a moment about the conference that was held in 2018. But as that conference has led to some initiatives, and I'll let him speak to that, one of which is the initiative to screen pediatric patients that I'm fortunate enough to Steve assigned me to be the chairman of this task force, to come up with screening protocols. But the vision is, if you're going to screen, you got to make it simple, and it's got to be overly sensitive, and it doesn't have to be real specific, but something that we can implement ultimately in the schools, where the school nurse can be involved in having all the kids every year screened through a simple questionnaire. And so we're now going through the process of validating something that we've spent a lot of time coming up with and correlating it to measurements of the mouth. And we're looking for dentists that see pediatric patients, whether pediatric dentists or adult general dentists that all see pediatric patients. We're looking for those that want to participate in our study. And I think later you can give a little more information on this, Mike. But the goal that I'm applying it to our current discussion, because once we have a better understanding of what the general population is like, and we see those that have these abnormalities, and then we see those that are having the interventions with expansion, we're going to be able to reassess them with the same tools. And we're going to be able to see the improvement. And when this statistically is bearing itself out, demonstrating that, yes, we're seeing clinically clear improvement by these expansions, but yet our tests that we're using to make this diagnosis are not necessarily picking up on it, then what's deficient about our tests? So now we make those tests more, we start doing better research and coming up with better standardization of the diagnostic process itself. This is my new thing, is I'm saying we're going to look back and say the 2020s were the transition of change. There was pre-2020 and post-2020, and the 2020s were when we started recognizing early intervention changes airways and changes the burden of obstructive breathing sleep on our community. but this is the decade of change. And I encourage the dentists to get involved, because if you don't get involved now, you're going to be missing the boat. Every one of your patients breathes, and you look at the mouth of every one of your patients. So if you know what you're looking at, recognize that you can play a role, even if it's just to refer them to someone else because you don't want to take on the burden, but learn something and you'll make a big enhancement in your practice.
What would you say to my dental colleagues, primarily, well, especially my orthodontic colleagues, who say that without a sleep study and an AHI on a child, let's just take it like a 6 to 8-year-old child, without a sleep study saying that they have an AHI that qualifies them to be diagnosed with OSA, that there should be no involvement of the dental professional in anything to do with that child's airway management?
And they're seeing anatomical anomalies?
Yes, completely. They could be
Well,
narrow. They could have high vaulted
they
palates.
could do the
Completely.
intervention based on the anatomical anomalies. Now, depends on how anomalous those are.
Mhm.
And some people say, oh, that's just normal variant. It's not really anomalous. Then that gets to be a point of debate. But
let's just say, for argument's sake, it's a narrow, high vaulted palate. It's a constricted lower arch, moderate anterior crowding, lateral incisors don't have room to erupt, insufficient tongue space, et cetera, and some signs that patient is snoring and having some issues with their sleep.
There's clinical manifestations.
Yeah.
I think that then they should intervene. But the sleep lab that everyone's looking to give that stamp of diagnosis isn't using parameters, isn't reviewing the data closely enough to identify the phenomena that's occurring during sleep. Not all sleep labs are created equal. All right. So people think it's, a sleep lab is a sleep lab. Polysomnogram is a polysomnogram. They did the overnight study. Yeah, but I know what goes behind the scenes in these facilities. And I know that it's the technician that's tabulating and scoring it. Is the physician reviewing what the technician did and enhancing the skill set of the technician to improve on this? Because frequently what happens is the technicians run the show and the physicians are so far removed from it. They just rubber stamp whatever they're given by the technician, and they don't even feel comfortable looking at the data because they don't do it all the time. They figure the technician does this every time. I'll just look at their numbers and I sign off on the results. And they may have passed an exam at one point in time and, just barely, but that exam is not really getting into all the little nuances of the fragmentation, especially if they took the exam a while back when it wasn't even recognized within the field as much. The scoring of hypopneas changed in 2013. They came up with the 1A versus 1B rule, because it used to be that in order to have a hypopnea, your oxygen had to drop by 4%. Arousals weren't even part of the definition. Then in 2013, they implemented the 1A rule versus 1B. 1B is the old, like what it used to be. 1A is that there's going to be a 3% desaturation associated with a 10-second or longer reduction of flow or increased effort, or an arousal. So if you could see a 10-second episode of changes in breathing where there's a reduction of flow, or there's increased effort of breathing, some changes in your respiratory signal, goes for 10 seconds, and then it leads to an arousal, that is now able to be called a hypopnea. But then they use a 30% reduction of flow based on a non-objective parameter. The flow is measured, it's subjective, it's not quantified, but there's a reduction. But it turns out that cannula has moved a little bit, then it may not pick up the 30% rate. So it's all sort of, that's why if you put a catheter down someone's nose into their esophagus, you're measuring that pressure. I mean, we do that, not on every patient, but we do that to identify those patients that would get missed otherwise. Very few labs do that. And there's a lot of debate within the field. People say you don't need that because the pressure cannula flow signal is good enough and is as good. It's not as good. We do that on every one of our patients. It is a good signal, but there are times where you don't see the change on the flow, and you clearly see it with the esophageal pressure monitoring. And anyhow, but the field needs to get better. Its tools need to get better. Unfortunately, the trend is to get minimized because they're becoming simpler, just wearing just a simple wearable to diagnose your sleep apnea. That's good for the clear-cut apnea, but that's not good for these more subtle forms that the dentist is being confronted with, because that person is clenching to keep the airway open. When they relax, they obstruct. From the brain says, oh, don't relax, clench. And they're getting fractions, and they're wearing down the enamel, and the dentist is fixing crowns, so the patients are breaking, and they don't realize it's an airway issue. So anyhow, we're in transition. Our knowledge is getting better, and the dentists play a key role. And I really want to see more dentists help this overall process of diagnosing and treating these patients.
So, Mike, you realize that everybody understands that in every profession, there's a stratification of interest, of commitment, of skills, of talent, of knowledge base, of, who's better, who's not as good. Every profession's that way.
Yep.
What you have on your podcast today is, I don't know there's a better sleep physician anywhere, Jerry. And I'm not just kissing up to you because I've told you this before. But in my community, I have a lot of physicians who have no idea what an abfraction is.
I thought when Jerry said abfraction, I was like, geez, that's impressive.
We don't hear
Yeah.
about that. And so what we have in this leader, Jerry, you bring these doctors and dentists together because you heartily believe in us working together. And I love that aspect of it. I look at the AASM, American Academy of Sleep Medicine, or American Academy of Dental Sleep Medicine, and AADSM, we have a few physicians that wander in because they're asked to give a presentation. At AASM, we have a few dentists that wander in because they're high-level dentists that want to learn some more things. But I don't see a lot of evidence of physicians wanting to learn what an abfraction is, or what bruxism really does.
Tori.
Or tori.
Right.
Or even what an oral, they understand there's oral appliances out there, but they don't really know what they do, and they don't understand jaw joints, and they just don't want to learn what we know.
I understand what the Bogue index is, the upper second premolar transverse distance.
See, those kind of things.
Yeah, exactly.
Right? So back to education and how we can make this work together is that when we think about little kids, we have to think about families. And when we talk to moms and they say, okay, what's going on with your kid? They're the expert there. We have expertise in what we do, but we always want to keep in mind that there are always two experts in the room. And one of us is medically trained expertise, and the other one is living the life trained expertise. And those things have to work together. And I think that when we distill it down to measuring an AHI and thinking, okay, that defines what we're going to do, that was fine. That was the only thing way back in the day, but that's not what they do today. In 2017, the policy statement came out. In 2017, or before the policy statement was even voted on, several of us looked at that and said, that's going to pass. That's going to become an ADA thing. And so what are we going to do with it? And my idea was that I worked out with a woman named Glenine Varga, who is a leader at the Still and was, one of my co-teachers. And she and I said, well, we ought to have a conference. And so I started putting together a conference. It took the ADA 7 months to agree to that because trustees were saying, well, why would dentists want to listen to a bunch of physicians? What would be important about that? And so I decided to put on a roundtable conference where we'd bring leaders together. So I started reaching out to the leaders in medicine, and Dr. Guilleminal and Dr. David Gazal, and immediately they said, yes, of course I'll be there. Dr. Guilleminal, what we should have done this 10 years ago was his words. And so everybody I asked came to this meeting, and I only had so many seats. I got to tell this story on you, Jerry. We only had so many seats around the table, and I had to have leaders of organizations there. The myofunctional therapists were there, the SLPs were there, the orthodontists. Actually, the leaders of AAO were there. That meeting, listening to the leaders of sleep medicine talk about how important this was. And then that still ended up with a white paper about obstructive sleep apnea. But Dr. Simmons heard about the conference and called me up and said, I got to be there. And I said, well, Jerry, they only gave me so many seats. I can't overfill this, but there's observers. So they said, we can put some seats around the table, but not part of the conference. And so he came as an observer. Well, it didn't take long for him to come to be it. I had to have him at the table because his ideas were so great. So we brought him to the table, and then the consensus of the conference decided that we needed a screener. And the reason why we needed a new screener is because we have two technically, but we have one freely available validated screener for kids. The Pediatric Sleep Questionnaire is a wonderful tool created by Ron Shervin in Michigan. It's 23 questions though. And it's 23 pretty detailed questions. And so you can't put that in the hands of a school nurse. And a lot of parents don't like 23 questions. And so what Jerry said, I wanted to chair this task force. And we had bunches of volunteers.
No. I just said, let me participate in the task force.
No,
You came back and says, I'll make you the chairman.
okay,
I didn't ask to be chairman, but again, I just wanted to be part of that task force.
Well, maybe I can count that on the list of decisions I came to that, in my life that are the good ones. And so they started talking together, and we came up with a name for the Children's General Airway Screener. And one of the myofunctional therapist leaders said protocol. And so we have a C-GASP protocol. And that's a subtle tribute to Dr. Diamano, who went by CG. So C-GASP is there. And so the Children's Airway Screener Task Force became a thing. Met a bunch of times under Jerry's leaderships to come up with, now we have 5 questions. 5 questions, 3 minutes, no special training required. This is behavioral questions because it's about how the kids are managing their way through life. And we want to make it valid so we can go to the healthcare profession and say, pay attention to this. This is valuable. This is important. Because there's a lot of screeners out there now. There's plenty of screeners for kids to identify who's at risk, but only one is validated, and it's 23 questions long. The simple is validated. And so they haven't made traction. If we're going to go to healthcare and change behavior, how we pay attention to these kids, we've got to use a validated screener that is published in proper literature, and we can stand on and go, look at this, it's important. And that's where Jerry's background in research and background in establishment of proper protocols is all super valuable here. And many other people on the cast are also well versed in this, and many clinicians there know what's necessary out there in the world. So, and as you guys listening to this will see, Mike's going to put a link to how you can participate, like Jerry was saying earlier, in the validation process for the C-GASP screening.
If someone does want to participate in the validation process as a practitioner, what does that look like from a logistical standpoint, including the time and energy they're going to have to put into this?
Well, maybe I'll address that. So what we're trying to validate this, okay, ultimately we want to validate it. We thought we'd validate it against polysomnograms. But the cost of doing that study, it would be at least $1.5 million to do it right. And we're not a funded entity. So as what we're doing in the interim is we're validating it against the measurements of the mouth. Okay. All right. And we're trying to see, is there a relationship between having these small mouths and these kids? And this questionnaire is designed from kids from 2 to 12 years old. So if you're a dentist and you're seeing kids within that age range and you're comfortable taking measurements, and basically we've got this whole thing digitized, it's all in the cloud. And we don't want people using it now just to use it as a screener. We're going through the validation process. So if you want to have access to this, it's because you're going to be contributing to the data set. And you feel comfortable, or you have someone on your team that's comfortable making the measurements. And we've got a little video you could watch from a webinar. And Loria Nahadis, who's a pediatric dentist up in Dallas, she's been very involved in the implementation of this protocol. She got it incorporated into her office, and she explains all the different measurements. But there's a series of measurements that you'll be making, and you identifying whether the primary dentition, mixed, permanent, and what's the bite classification, and then certain measurements, primarily transverse measurements. So anyhow, if you do that, then you can participate, and we need your data. We don't want just those that are going to be compromised children. So if you're an orthodontist and you're seeing all these kids with malocclusion, you can participate, but we're really looking for those that are seeing the whole spectrum of the population, normal kids as well. That right now, normals are more important to get good normals than those that are abnormal. And the parent fills out the questionnaire, 5 questions, boom, 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 and it goes up to the cloud. We're anonymized. We don't have the identification of the patient, but they're assigned a number. But then after they do that, then there's another email that goes to the back office and through those that are going to be doing the measurements. And they just fill it out online, boom, 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 the different measurement results, and then it goes into the cloud. Now the dentist can get that printed out in their office. They can upload it into their chart on that patient. But we're accumulating that, and we're looking at the statistics if there's a relationship.
But the key is it's simple and fast. It's not, you don't need a cone beam X-ray. You don't need even a Ceph. you need a ruler and you need a few minutes.
Mhm.
And it's all you need. So Jerry mentioned doing polysomnographies. Yes, but those things are hard to manage, very expensive. And if anybody listening to this has an extra $1.5 million sitting around, love to fund the C-GASP project for that. But in the meantime, instead of waiting for that to show up, well, Jerry's idea is to gather this from a lot of clinicians on a lot of kids, and that will help us establish the value of a simple test like this. And when we can do that, now we can put this in the hands of non-specially trained healthcare providers or people interested in kids.
Mhm.
And that can change the vast population of unaware or actually more likely puzzled parents
Mhm.
into, okay, I have a pathway parents.
Mhm.
And wouldn't that be nice?
And puzzled doctors. As we started talking about, by simplifying this, the things that we have been talking about throughout this episode of the time, the resources, the energy, the fear, the liability. If you have this validated C-GASP screening tool that is just a way to start to simply evaluate these children who may be growing abnormally, and it may be having an impact on their airway and therefore their sleep and therefore their temperament and therefore their neurocognitive development, et cetera, et cetera. That would be so huge. I just want everyone to take a moment and think about that, because I get asked so often, Mike, I don't know where to start. I don't know where to even begin to think about this. I don't even know what questions to ask. And I refer them to the Shervin PSQ as well, but it takes time. As you said, there's time involved in that. And so this is such a great place to start. And you could even then precede that visit to the physician or to the dentist by having it in, say, the schools, and start to detect some of these problems like we detect eyesight and hearing and all things we know can impact the neurocognitive and behavioral development of these children. Take even the craniofacial side out of it and the dysmorphism that is occurring on that side, just simply from the performance of these students. It's not out of the ordinary. When I first spoke with you guys about this, I think it was probably a good year ago now, or maybe last summer, it made so much sense to me. So I would just encourage everybody listening. I will put links in the show. Please consider helping them gather this data, because this will be one of those huge key pieces to this puzzle to start to simplify this and allow you to implement basic screening measures into your practices. And I say all the time, so often we're told screen American Academy of Pediatric Dentistry, American Academy of Pediatrics, American Dental Association, American Association of Orthodontics, screen for airway. Most of us don't know where to begin. And this could give them a great spot to launch from.
And if you're an orthodontist, you're getting referrals from your community. And probably what would be very helpful is if once you start getting into this space, is to reach out to your primary, your dentists or pediatric dentists that are referring to you. They're the ones I'd really like to see participate in this study. You can learn and become comfortable with it as well, but maybe then you can have those discussions and maybe encourage them to come to the consortium. And I'll tell you, we're giving group discounts, pretty steep group discounts. It's on the webpage that the more you get into your group, then the greater the discount coming to the conference. And then if a dentist gets a physician, we'll give even a further discount. Call for the phone number that
I'll put it in there. Yeah. Yep.
And because you'll get at least a $300 discount if you get a physician, and the physician will get a $200 discount on their admission to the conference if you go together. And then the more dentists and more physicians will give even more of a discount, because we're not doing this for the money. We're doing this to enhance the message and to improve the overall healthcare. So if you're interested in the C-GASP, if you register, someone from my office will be contacting you to walk you through the process, but also to point you to what videos to watch. And we'll be engaged with your office to get you through this early learning curve to get this implemented so you can gather data. And we're really looking forward to that.
Many times throughout this, as I think in my head doing this and producing these episodes, and I think of the clips as people say things like, oh, that's going to be one of my highlight clips. And I usually try to get that down to about a minute for the quick hit social media. And I'm like, it is really going to be hard to clip a minute of highlights from this episode with you both, because you just have so many pearls and so much insight and so much experience. And the fact that have both been doing this for a number of years, and have been fighting for a number of years. It is a grind to fight this fight. Yeah, I've been in it for a shorter period of time than both of you. And it is a grind. It is a challenge. It's an uphill battle. And the fact that have been doing it for decades now and still have the energy to fight and be innovating and thinking of new ways to try to move this ball down the field for this agenda of getting greater awareness in the sleep arena is amazing. And the fact that you can articulate it so well and teach it so well. And I can't tell you how much I appreciate you both coming on. All that you do first for this profession across the board in each of your respective professions, and then together, then coordinating the professions between medicine and dentistry, because that is a huge problem, is the siloed nature of this. And then on top of that, sharing it. I just so appreciate it. So before we hop off, I'll put the links I had referenced before, but any other ways that you want people to connect with you or get in touch with you, or if they want to learn more about what you're doing that I could put in the show notes? Steve, we start with you.
Well,
yeah.
Yeah, I'm the chief dental editor of Dental Sleep Practice magazine. We started that 15 years ago as really about dental sleep medicine, which at the time was oral appliances for sleep apnea. Now we're branching it forward. We've got a chief medical editor now. There's an article about myofunctional therapy in every issue. We're talking about nutrition. We're talking about early intervention. So if the reader is interested in this topic, I urge them to go to dentalsleeppractice.com, and Mike, I'll give you a link, and they can sign up for a free year of the magazine. Oh, that's a good thing too. And there's CE involved. So there's lots of ways to learn. But the last message is really what I said earlier. Stay curious. Mm-hmm. Be an involved dentist. If you're a dentist listening to this, if you're a team member, ask your dentist, what are we going to do about this? If you're a dentist and a team member together, like Jerry said, the more we bring together to learn, the better off our patients are going to be. Mm-hmm. And so learn together, form a team, be a group, get your study club to invite a physician, an ENT, a sleep doctor, somebody, and talk to you about the implications of these things. Maybe you'll educate the physician a little bit too, mm-hmm. because as we all learn together, our patients suffer less. And that's excellent.
And if you're a parent, I would just add, push your dentist and your physician to be more aware of this and not ignore it. And I hear all the time, I get so many emails and messages on social media. What do I do I went to 3 orthodontists or my pediatric dentist, whatever it is. I tell them there's something wrong. I've heard some content on this online. I've heard some of your content, and they just tell me it's not a thing. So parents, keep pushing. Send this episode to any skeptic. You have 2 world-renowned experts on this topic talking right here, and that could be a way to help educate your providers. Jerry?
Well, I mean, there's a long list. I think go to the consortium. You can actually also download some videos from the Sleep Education Consortium main website from videos. We have a paywall, and again, it's a nonprofit. So the money actually goes to help fund our C-GASP study and other related types of things. But you can download some videos, but there's a long list to start looking at. My practice, Comprehensive Sleep Medicine Associates, our webpage is csma.clinic. There's learning, there's some educational content on there as well, and links to some other things. I get referrals from other clinicians from around the country that they'll fly in Texas. We have 2 offices in Houston, 1 in Austin. But we do telemedicine consults, people that are out of state. And there's a lot of educational opportunities. The American Academy of Physiologic Medicine and Dentistry, the AAPMD, is another organization that has as a goal to bring doctors and dentists and physicians together. And Steve and I are both involved in that organization. And there's just other opportunities. If you look, you will see. But if you don't look, you're going to go nowhere.
Mm-hmm. Yeah, well, thank you both so much. This has been an absolute pleasure for me, and I know everyone's going to get so much out of this. So I just want to seriously thank you both for all you do, and thanks for taking the time to be on the show today.
I appreciate you doing here too, Mike. Thank you very much for putting your word out there.
Definitely. Thank you.
Thank you. Awesome. Take care. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the doc community on Facebook for more great content. Thanks so much for listening. And always remember, you have been blessed with the ability to do amazing things.